willkommen, herzlich willkommen alle. You have now entered the cosmic radio receptors of KCIW 100.7 FM in Brookings, Oregon. Thank you for tuning into this week's extra fabulous program. I'm Dr. GiGi, and my co-host is usually Jacques Kepner, but he's away for a couple of weeks, so he won't be here in person, but certainly in spirit. And as a matter of fact, I know he is listening to our show today in Missouri. Go Missouri. So he's having a listening party. Hey, Hoppy. Hey, Elizabeth. Is that Purdy? Dr. Sherry, Chris Nelson, Darwin, Pearl, Rebecca, and of course, lovely Jacques. Thanks for listening, and hello to everybody. So, for this reason, our format for the Doc and Jacques show is going to be a little bit different today. However, as Jacques used to say, I do want to mention that you are hearing this live show on KCIW in Brookings, Oregon, as I said before, but he always repeats it anyway. Having said that, the same show will be rebroadcast in exactly 1 week from now, each and every Wednesday on KZZH 96.7 FM in Eureka, Humboldt, at 8 a.m. in the morning, and then a few hours later at 1 p.m. at KFUG 101.1 FM in Crescent City, California. So, as mentioned above, the format is going to be a little bit different. And before we start our MD10 segment, I want to introduce my guest today. I'm not an English major like Jacques is, so my prologue or introduction won't be quite as poetic as what you have heard in the past out of Jacques' mouth. So, when Jacques and I were thinking about making this very radio show, or this kind, we subtitled it with Ladies First. We wanted to highlight women who have excelled in what they're doing best, especially in a man's world. One of the first guests that we were planning on interviewing is my guest today. Now, almost exactly 2 years after starting our show, we finally got her here. My guest started her career as a physical therapist in 1988, became a certified manual therapist in 1997, a board-certified orthopedic clinical specialist, whatever that means, in 2015. Meanwhile, she got a master's degree in orthopedic physical therapy in 2000 and then proceeded to get a PhD in exercise sciences in 2005. She became a fellow of the American Academy of the Orthopedic Manual Physical Therapist in 2016. She's now a tenured professor in the Department of Exercise Sciences at Brigham Young University in Utah. She was the only female professor in that department for years, which has, however, since changed. She has published multiple papers on restless leg syndrome and low back pain. She has been invited to speak at several conferences about her findings and was recognized at the University of College and college level for her teaching and mentoring in 2021 and again in 2025. Wow, so you wouldn't think this is a talk show. So anyway, she also happens to be my twin sister. Therefore, as Jacques likes to say, without any further verbiage from me, I want to introduce Dr. Rike Mitchell. Welcome to the Doc and Jacques Show, which for today we will rename to the Doc and Doc Show. Welcome.
Thank you. Thank you for having me on the Doc and Doc Show. I came all the way from Utah to be here with quite some stress, so you can tell how excited I am about this opportunity.
Right. So as a matter of fact, we didn't even have time to talk. She flew into Medford, drove down, had to wait at the Jedediah Smith Park for some sort. Anyway, we did not meet up till just now before the show. So, but she's here. So let's proceed with our MD10, or MD PhD 10, I should say. Today we're going to be talking about physical therapy and how it helps with the healing. Because, you know, she's a physical therapist. Most commonly known is the physical therapy is the fact that it restores some kind of range of motion, right? Physical therapists use the techniques like stretching and joint mobilization to prevent stiffness and excess scar tissue formation to keep the joints flexible. But it also is used to rebuild strength. So they have those so-called targeted exercise that strengthen certain weakened muscle, which of course is crucial for regaining function and stability. So where I work, for example, we do see patients for deconditioning after a bout of severe sepsis or other occasions where they need to rebuild strength. If I think about physical therapy, I usually think about the rebuilding of strength. What do ye say?
Yeah. So rebuilding strength is an important factor in PT. But if you think about it, you could also go to the gym if it's all about the strength.
Yeah.
So in physical therapy, we also try to improve functionality of a person. So we're working on functional strength, balance, independence, and movement dysfunctions. And actually, physical therapists are considered to be the movement specialists.
Oh, wow. Well, let's move on to other things. Physical therapy can also prepare for treatment. Patient can use physical therapy to build strength and maintain function before cancer treatment begins, helping them to tolerate aggressive therapies better. We do send patients to physical therapy before hip surgery, for example.
This is pretty new. It's called prehabilitation, and we we put people on strengthening program before surgery. So we teach them exercises that they will have to know right after surgery when they're more confused. So we teach them when they're not confused, and we teach them about what they can expect to happen. So I think prehab is a big part of successful physical therapy.
Yeah, we send them all the time. Not for every joint change, but hip, right? Is that the most
Hip and knee.
Hip and knee. Physical therapy also improves circulation. So exercise and movement enhances blood flow to the vital organs and non-vital organs, I'm sure, and the injured areas, which promotes then faster and more complete healing.
Yeah, this is the part of therapy that does not often get talked about, but it is so important to healing. Could be after surgery, after a stroke, or any other immobilizing injury. Circulation is, of course, always important, but even more so if you need to get oxygen to the injured site, like you said. A lot of people are afraid of moving after surgery or after they had a problem. Yeah, and so it's really important for us to tell them that pain is not always a warning sign. It might just be a sign for the tissue being maybe aggravated, but it's important for healing, and it won't make the injury worse. But you always have to ask the doctor, and he or she will know what to do. But chances that the doctor will want you to move to promote healings are big.
Wow, cool. All right. So there are other specialties in physical therapy. So for example, we have physical therapy that helps cancer patients.
That's right.
So one, of course, is the regaining strength coordination with cancer people who get chemotherapy and then they're tired and then everything is sapped out of their body because of the chemotherapy. Then it reduces pain and fatigue by helping them to move around a way that they can manage without actually getting exhausted. And it can manage side effects. So
let me just real quick talk about the specialty of oncology physical therapy, because that's actually relatively new. The first certification was in 2019. So if you think about it, 6 years ago. And they started with the process in 2016 when they said, okay, there should be a specialty in oncology. And then they had to make sure that the test questions were set and all that stuff.
Oh, very cool. Yeah. So some other side effects in the oncology is actually the lymphedema. You can have lymphedema without having cancer, but especially breast cancer, when you take lymph nodes out, a lot of people are left with lymphedema, very waterlogged arms or limbs. So I have sent people for physical therapy for lymphedema, and most likely because it wasn't a very known subject at that time, they had to travel or they had to find somebody who was actually certified for that. It's most likely super important, I think, because lymphedema is very functioning limiting.
Yep. So especially in breast cancer patients or post-mastectomy, there's a lot of lymphedema in the upper extremity in one or both arms, and people lose functionality because there's just so much fluid in their arms. And lymph drainage, which is the skilled massage technique for lymphedema, takes quite a bit of education and practice. And it's kind of like a specialty within physical therapy as well, but it can be very, very beneficial.
Wow. Now, you can also have physical therapy for neuropathy. So you have some nerve damage leading to pain or decreased sensation, which is treated with specialized exercises. What to explain nerve gliding activities? Okay. What does that mean?
So I worked a lot with people with neuropathy. Let me just step back. So neuropathy is when people lose their feelings. Could be because of cancer treatment, but it could be because of diabetes. I actually think that I have seen that much more, that they have decreased sensation in the soles of their feet. And they don't notice that maybe they injured the sole and might be some opening or a wound. And because they have neuropathy, there's decreased blood flow to that area. So this area might get infected and people don't even know about it. So this decreased circulation to the skin that comes with neuropathy is really a double whammy. First, you don't feel when you injure yourself, and then it inhibits the healing process.
Yeah, darn. Okay. Any other little excursions?
Yeah, I have a couple more, like why we do PT for cancer patients. And usually it's to treat the side effects, like you said. I just wanted to maybe go into detail. The pain and fatigue are the worst side effects from cancer treatments. And therapists can't take that away, but we provide education and techniques to manage discomfort and maybe explain or show them some exercises that reduces the debilitating effects of the fatigue. And then, like earlier, we help them with increased function. And if there's balance problems due to cancer treatment or neuropathy, then we help with balance training.
All right. How do you do balance training? Have him hop on one leg?
Well, that would be for later on. But we have these, 3-inch cushions, and we have them stand on it and just retrain the proprioceptors that are in the ankles. These are like sensors that tell the brain you're standing awkward or you have too much sway or something like that.
Well, cool. All right. Thank you. That was a nice little excursion into physical therapy and some of its application as far as I can handle on my side. You are now warmed up to hear more about physical therapy and findings and experiments and results and research by a professional. But before we get into all of it, let's delve into getting the skinny from my guest today, Rike Mitchell. So here are the questions. Where were you born and raised?
This was a tough one for me because it's the same one as GiGi. So we were both born in Castrop-Rauxel, which is in Germany. And we were also both raised in the Black Forest. When we were about 1 year old, we moved to the Black Forest, thank heavens. And we stayed there until we were older.
Ja, genau. Möchtest noch was in Deutsch sagen?
Ich glaube nicht.
Okay. Okay, well, so, and then we go on. When we got older, is that how you ended up?
That's
when
how
we
I
got
ended
older?
up. I didn't want to say old because we're still not old.
So the first pathway that I happen to know, because you're my sister, the first pathway to college was to become a French and physical education teacher for high school. You even lived in France for a little bit. What changed your mind?
So like so many people in Germany at that time, I wanted to become a teacher because you got 6 weeks of vacation and you got really good pay. It's not really the same situation here in the States. You don't really get paid that much. And our older sister, Bärbel, she also was going to be a teacher. And by the time she graduated, she's 5 years older, so she graduated about 5 years before us. She was on the street, basically, because there were no jobs available as a teacher because everybody wanted to do it.
Yeah.
So basically, that was my wake-up call. And I thought, what else am I going to do? And I thought physical therapy would be great. I really didn't really know what physical therapy was. I just received it one time for my shoulder. I'm like, that would be cool. So I applied.
So how long does it take in Germany to become a physical therapist?
Well, when it was my turn, it just took 2 years, but things have changed. And keep in mind, it was, let's just say 30-ish years ago, maybe more like 40, almost 38, that I went to school. So at that time, it was 2 years. And I believe now you can actually get a bachelor's degree in physical therapy. And that's, of course, more like a 4-year education.
Yeah. So did you ever work as a physical therapist in Germany?
I did for about 2 years.
Okay. That must have been fantastic since that's all you say. When did you move to the States?
Well, I visited the States for about a year after my PT school was done because what is now called a gap year, I didn't know that then. I didn't really want to go to work full time because that meant the rest of my life was prescribed. So I went to the States and teach German and French at a couple of schools. So
Marietta, Georgia.
Yeah, in
and I came
Marietta,
to
Georgia.
visit.
Yeah, it was pretty fun. And so when I came back to Germany, I missed speaking English and I went to an American church and I met my future husband there. And after we got married, we came to the States. And I've been there ever since.
Yeah. What happened next, education-wise? And especially, why did you keep going further and further to get this and that and all these numbers and thingies behind your word, behind your name?
The letters.
Letters. And
So I think education is exhilarating. I love getting more skilled or know more academically, and I just have fun studying and learning. So again, I came over with a bachelor's equivalent degree in physical therapy. But about that time, all the PT programs in the States, they transitioned from bachelor's to a master's degree, and they offered bridging programs for those who had a bachelor's and wanted to become a master. So I enrolled in one of those, and 5 years later, I got an MS in orthopedic manual therapy. And later on, those programs shifted again, and right now you get a doctor of physical therapy, like a DPT. And I considered pursuing that, but a wise friend advised me to go for a PhD instead. So just for the listeners, a DPT, a doctor in physical therapy, is a clinical degree, and a PhD is an academic degree. And as such, I'm involved in research. And I love academia and I love research, but I still love the clinical side. So I treat patients still, and I advanced my training in manual physical therapy, and I became a certified orthopedic PT, and then I became a fellow, like Gundi said earlier. So I just always try and continue to learn and study and get better.
okay, so let's say you are working. So what does a normal day at the university look like for you?
So this is really funny. I am busy all day. And when I asked a professor at BYU where I was before I started, I asked him, what do you do all day? And he said, oh, it's just always busy. I do research and meet with students. I'm like, how busy can that be? But I am so busy. I spend a lot of time preparing and teaching classes. I teach 2 classes a semester. I meet with students about their coursework and research. I collaborate with colleagues on teaching and research projects. I'm the graduate coordinator, so I work closely with graduate students and their mentors. Right now, for example, we are revising the PhD comprehensive exam to better align with the BYU aims. And then lastly, I'm also the faculty liaison for the PTOT, which is Occupational Therapy Club, which means I regularly meet with students involved in that group. And when the teaching, advising, and meetings are done, I finally get to dive into research, which I really love. I collect data, I write, and explore the latest literature.
Okay, though, so you teach 2 classes a semester. What classes do you teach?
So this year I teach orthopedic impairment, which is a class that focuses on joint problems, including the spine. We talk about scoliosis and how to design exercises to help treat them. And then I teach, but not this semester, advanced musculoskeletal anatomy, where students learn more than just the fundamentals. We learn terminology, bones, nerves, muscles, and ligaments. And at the graduate level, I teach an extremity mobilization, where students practice techniques to mobilize the joints of the arms and the legs, as well as, get this, the larger nerves. We mobilize the nerves, which you earlier mentioned. That's nerve gliding.
Oh.
And then lastly, I just started teaching a brand new class that's unique to BYU, and it's called University 101, Foundations for Student Success. Yeah, it's kind of fun.
What is it? It has nothing to do with physical therapy.
No. It's like we get all the freshmen. There's like 250 sections offered to catch all the freshmen. And we want to make sure that they have friends throughout the time, because there's so many students that graduate and they never had a friend. They never had a peer that they hung out with. So we do a lot of get to know each other. They talk about the idea behind BYU. And it's just a really fun, in parentheses, a lot of work for me, class for the students.
Okay, so you said you teach orthopedic impairment or exercise or something. Wouldn't that be something fun for people, people who have that, not just for the students? Can you go and do a service and go to a hospital and say?
Yep. Well, I could, but
in your free time, I mean.
I was just going to say that I was asked once to talk in our gerontology department about those things. So if I get asked, or there was a university-wide, it's called Well and Wise, and I talk about how to take care of your back. So I do. I don't look for those opportunities, but maybe I could.
Well, you have some pearls for us later on.
I might
take that away. Do you have graduate and undergraduate students?
Yeah, right now I have 2 master's students. One is in her 2nd year, so she'll be graduating in a year, and one that just started. And then I have 7 undergrad students that help me with my research, or I mentor them.
How to do research? Is that what you're mentoring them?
Yes.
Do they get paid?
Yes.
Whoa. Dang. Okay, so tell us about your research. What do you research?
So I probably won't shut up. So you have to tell me when to stop.
In 3 minutes. In 7 minutes, I have to do the mid-break. So.
Okay. So my current research focuses on chronic low back pain. More specifically, I'm studying pain that comes from the intervertebral disc. A healthier disc is typically more hydrated. It has more water. So one part of my studies are exploring ways to improve disc hydration as a potential treatment. If we could figure out how we can increase the water content in the disc, I think we can keep it healthier longer.
Drinking water.
Yeah, that's what students ask me a lot. Is it helpful? I'm like, yeah, I mean, you shouldn't be dehydrated, but I don't know whether more water will pump more water to the disc. But, I mean, nobody has done that research because I looked at it.
I want to be co-author.
So I'm also collaborating with colleagues in the mechanical engineering department to study how people with chronic low back pain move. We're trying to find clusters of movement patterns that maybe we can use to design treatment options for. Once a pain has moved on to chronicity, the brain has changed. The synapsing changes. There's just this big overlap.
Synapsing?
That connecting.
Information from nerve muscle? Okay.
Yeah, so that has changed. Plus, there is this psychosocial overlap, meaning psychology and the social environment just changes when you have chronic pain. So we're trying to find out if we can find movement clusters. We call it phenotyping. Maybe, let's say, we have 7 phenotypes and we can treat these different phenotypes differently and get them better.
So 7 different ways of how people describe their lower back pain.
Well, we actually have the move. So the engineering department has developed these sensors. So we have a move, and some move always slower into forward bending, or they don't like to twist or something like that. It has to do with speed and their range of motion, how far they go. And we're hoping to find these clusters that we then treat. Because by the time a pain has moved into chronicity, it's super hard to find the origin or the etiology. And once you found it, it might not even be there anymore because you have that psychological overlap.
So, okay, so you find your clusters, 7 ways.
Would be 5.
Of how people move when they have certain back pains. So then what? I mean, how do you help them?
Well, in theory, we're not there yet. But in theory, we think if they have, like, they don't reach forward as much as normal people do, then we would maybe do mobilization or range of motion into flexion, right? What they're impaired in. Not worry about the cause, just what are they impaired in. And our assumption is when they move like quote unquote normal people do, those without chronic low back pain, we might have helped them with the pain as well.
Okay, has that been done yet? I mean, does that research come from an origin saying, hey, this person who always stooped over a little weirdly, and now we tell him how to stoop, otherwise he has no more back pain?
No, that's why we're in this life. We're trying to find whether that works. Nobody has done the phenotyping because everybody's trying to find the origin. But by the time...
Yeah. Oh, okay, so that's the newest approach. Because for back pain, when you have, I don't know, whatever the X-ray says or the MRI says, then I said, okay, we'll send you to physical therapy if the neurosurgeon is not indicated. And we hope that the physical therapists know what to do.
You know what? This brings up a fantastic point. We get a lot of people that have and come back with the MRI and say, the MRI says I have this and this. Well, guess what? The MRI picks up everything. We call it's very sensitive. So it picks up everything, even if the pain doesn't even come from that. I might have a herniated disc, for example, but I have no pain.
Yeah.
Somebody else might not have something that is shown on MRI and they have pain. So, so we're trying to just take that out and just do the movement clusters.
Okay, but so far, somebody has scoliosis. Let's pretend, I know it's not the real treatment, but let's just pretend scoliosis goes to physical therapy. We just send anybody, doesn't matter what the degrees are to physical therapy. How are the physical therapists educated in knowing, well, this is really the wrong, we don't, or you have to do what cluster 1 does and not cluster 2. Do they know? How do they get the training?
Well, if they come because they have scoliosis, it's not chronic low back pain, or, So
that was an example. I know. If I say litholysis or whatever, nobody knows what I'm talking about.
No, I was just trying to understand what you were saying. So I don't know whether I understood correctly, but we don't care why somebody has chronic low back pain, if it's scoliosis or whatever big word. We think that once it's chronic, they just need a certain treatment. We just don't know which one. So we're thinking about the movement pattern. That's not what you were asking, huh?
No, I'm asking, so that's kind of like I'm asking, right now, the physical therapist, you have this diagnosis, so you do this treatment, right? I mean, that's how it is now. So you're trying to actually go a little bit deeper, and then the physical therapists still have to be trained for that.
Yeah, you're right. I'm sorry, I misunderstood. Yes, right now, you come with scoliosis and you should do certain things. That's almost prescribed.
Right, yeah, that's what I thought. Mm-hmm. Well, but guess what? We are halfway done already. Yeah. So time flies when you have fun. It's that mid-break time at the Doc and Doc live radio show. Okay, Doc and Jock in real life. And we are proudly broadcasting from the KCIW 100.7 FM studio in lovely coastal Brookings, Oregon. And I want to list the major sponsors for our community radio station. We have Advanced Airlines, which is flying in and out nearby Crescent City to Oakland and Los Angeles 7 days a week. Michelle Bupert with our own vibrant local Curry County Chamber of Commerce. Nick and Lisa Rail and the PPA, the Partnership for the Performing Arts, don't remember anything, the medical team at the Chetco Medical and Aesthetic in Harbor, where I happen to work. And me and Jacques, we are also sponsors. On behalf of KCRW, thank you all of us. So let's go back to our guest here, Dr. Rike Mitchell, my twin sister, who is a physical therapist exploding into PhD and whatnot. So you have to scale back and find out all what she has done. We're talking about her research in low back pain, and I think I start to understand what the research is for. It's for the future. It's for the next generation who then knows how to treat the different clusters. Unless you have anything else to say, I want to ask, how do you do research?
So first, you have to find a field that you're passionate about. For me, it was low back pain or chronic low back pain. And I even was interested in that as a physical therapist. Then you dive into the literature and read everything you can find. You will find thousands of papers, so you have to not narrow it down. For example, I narrowed it down because I became interested in why do intervertebral discs dry out? I tried the increased water intake. That didn't really work. Go. So then I thought it was part of aging, so I'm thinking there must be a way to slow the process. And just so maybe the listeners can appreciate this super interesting subject, I want to explain real quick how a disc works. It's kind of like a sponge. Compression, when you push on it, that pushes the fluid and waste products out, which is good. And when you pull on it or let it sit there without pressure on it, then it sucks up the fresh nutrients and water. Yes, exactly like that. So that let me wonder, could certain physical therapy techniques improve disc hydration? And when I looked at the literature, I realized nobody has worried about that. Again, that's why I'm in this life. There was a research gap, and filling those gaps is how new knowledge gets created.
Yeah.
So sometimes, though, so I was just wondering, right? And I made my own thoughts and I found a gap. But sometimes it starts with a new hypothesis. For example, in my case, I wondered, when you run, you have, with every step, you kind of squish water out of the disc. And then when you're in the air, ever so slightly, there is some distraction on the disc and it can suck up the fluid, like you just said. So I thought, is running good for low back pain, chronic low back pain? And keep in mind, not if you have a fracture or if you know exactly what's going on. I'm talking about the disc is the culprit, right? So we did...
And not protruding and pushing on the spinal cord.
Right. Just a degenerated...
Just a little bit.
Degenerated disc.
The wear and tear.
So basically, the essence of research is you ask questions, find gaps in what's known, and then you design careful studies to fill those gaps.
Okay. For example?
Well, since I talked about the running, we did this study where we invited 40 people with chronic low back pain to our study. 20 were put on a running program, and 20 just did whatever they did before, which was not running. And we found out that most of them, so statistically significantly, amount of people had decreased pain after the running program. And we also found out, as an FYI, that people are afraid of running. They don't think, I hate running or I'm lazy. They're afraid that it makes it worse because they're being told from neighbors or something, somebody, that it's bad for you. So they've thought, well, I'll try it because,
Isn't it?
It's not. Well, it depends. If you have a fracture, obviously it's bad. But if it's just a degenerated disc, which usually or often chronic low back pain comes from, then it's actually a good thing to do.
Hey, Schnulle.
Ja.
Ich frag dich jetzt mal was.
Okay.
What is a physical therapist's favorite coffee?
I know that one. Tensorfase latte.
Nice. Okay, continue. That was my plucky intermission. Go ahead with your low back pain stuff.
We're good. That was a good finding with the running and it being good.
Okay. So what can one do now that we have our low back pain, because we have been around the block a couple of times, so we don't really want to be running anymore because running that ship has sailed. We're already older. So what can we do?
So you don't have to necessarily be running. And I should have been more clear. It was a running/jogging/walking program.
I like the walking.
Like the participants were told every week, how far did you go? And then let's add something to the distance. They might have just gone 20 seconds at a time and walked for 2 minutes. So the next week they maybe ran 25 seconds or so. It was slowly increasing in magnitude, but still, it helped. But for those who have chronic low back pain, any movement is good. It's good for so many reasons. Cardiovascularly, right? I mean, if you bring your heart rate up, cardiovascularly, that will help. And chronic low back pain will not want to be a couch potato. So you need to get off the couch or off the chair and just move around. Backs want to be moved for the reasons I explained. It wants to be squished and it wants to be in a situation where it can,
free floating in the air.
But yes.
Okay, so it happens too that you don't just do the talking, you also do the walking. You're known to have run marathons, many of them. Is that still something you do?
No, I ran 20, which was a goodly amount.
Goodly.
Yes. But no, I don't run anymore because my knees have vetoed that sport big time. But I still stay active. I try and do at least an hour of cardio every day, which I won't get to do today because I've been sitting down since 7 a.m. to get here.
Because she flew in here and then she was in the car.
But
We'll be at the beach later.
Yeah. But I lift weights from time to time. I personally don't like it, but I know how important it is because our bone density goes down with age. So lifting weights it doesn't have to be tons and tons of weight, just some poundage that will benefit the bone strength. Yeah.
So you told us about how to design the tests, like, frolicking in the air. And I was thinking about any other fun stories that you can enlighten our hearts with while designing a research.
I really have a funny story to tell. Actually, I thought it was funny. Maybe you guys don't think it is. But a few years ago, I wanted to study, very apropos, whether the intervertebral disc absorbs water when placed under traction. And because that wasn't known then. And I wanted to put the person in the MRI, take an MRI before, and then while in the tube, put weights on the person. So
to stretch them.
To stretch.
Yeah.
Now, you probably all know that you can't bring ferromagnetic materials in. So anything like metal, you can't bring in. So my then PhD student and I decided to get creative. We built like a scaffolding, like a traction scaffolding using PVC pipes around the MRI tube. And we wanted to hang about 20 pounds of water weights using milk jugs filled with water. So we did that, and we thought it was just the best idea when the whole scaffolding collapsed in the MRI room.
Uh-oh.
So we're not engineers, so we had to redesign this whole thing. But it did work, and it was a great study. And I did show that traction increased water hydration in the discs.
So what do we do with that knowledge?
Yeah, that's a good idea. It's a good thought. I tell you what I do. At any time I can, I push off a seat, for example, like the armrest, and I push off that my bum is kind of in the air. It doesn't have to be that high, but you take the pressure off of your bum when you push up.
Mm-hmm.
And when you listen carefully, which I always do, you do hear the discs make the sound. Because they do take in the water. We call it imbibe the water. They do some imbibition, which means that new water nutrients come in, and then when you let go, you feel the water come out again. And if you think about it, after you go for a long walk or if you run, then you are actually shorter after that exercise. And you're also shorter at the end of the day if you sit or walk a lot because the fluid within your discs gets squished out. So you want to make sure that during the day you can get it absorbed again. So this is a good exercise.
And so how long do you hold it up there?
So I can't, but preferably would be 2 minutes. 2 minutes has been shown to make you get the biggest bang for your buck. But if you do like 10 seconds at a time, just do it when you have to sit all day. It's very beneficial. But I have another one too.
Oh,
so when
great tell.
You lie down on your back and you bend at your hips and your knees about 90 degrees. It's the 90-90 position. And then you put your feet on a cushion or something and push ever so slightly with the feet down. That kind of lifts up your bum too, but it also elongates the spine. So in that position, you don't have gravity pulling down, but so it's gravity eliminated almost, and it has time and hopefully enough fluid to get rehydrated. But you have to listen carefully.
Okay, so what about the inversion chair?
Oh, so I have an inversion table. So what it is it's like a board that you strap, you stand at it, you strap your legs in, your feet, and then it tilts backwards. So theoretically up to 180 degrees down, like perpendicular to the ground, but you don't have to be that much inverted. You can be like...
All the blood is in the head then.
Yeah. And especially in the beginning, you might not like it, but I've done it for so many years. I love doing it. So you go down to, if 90 is horizontal, maybe 120 degrees or so, and just sit there. And I tell myself, because research has shown it, 2 minutes is enough. But start slowly. You don't want to have a stroke because you have to.
I know. When the eyes pop out, maybe that was too long. Pick them up, put them back in, and then don't do it that long anymore.
Yeah.
So the research sounds fun. Who pays for it?
Yeah. So I'm super lucky. Our department pays a lot for it. We can just ask for an internal grant, and we usually get it granted. If the chances that the paper gets published are great. But I mean, you don't get tens and tens of thousands of dollars. I mean, a couple thousand to pay for subjects, for example. And then I'm super blessed because we have an MRI at BYU, and we pay a couple $100 per hour, for example, to use it for research. It's not meant to be a clinical device, but for research, we can use it, and we get $5,000 a month to use it for free.
Dang, I should have done that. I came down there and then something happened. Why did I not get that MRI?
I think we wanted to do a DEXA.
Or memory that. Do you have a DEXA?
Yeah, we do have
What's
DEXA.
What's the DEXA scan for?
So the DEXA tells you bone density, and it's like super fast. Whole body scan takes like 14 minutes or so.
Super fast. Okay.
Well, it's actually 7 minutes, but then you also do the extra bone stuff like the spine and the hip. And that's like the whole package. And it tells you bone density of the hips and the spine because that's usually where you have the fractures, like you fall and you break your hip. Or, interestingly, often you break your hip and that's why you fall because your bones are so brittle. So we have that scan. It can also tell you like body fat percentage and lean tissue, stuff like that.
All the important stuff to start losing weight. So let's go back to the more... Oh, wait, I first want to do a joke. What did the physical therapist say to the bodybuilder with a herniated disc? You don't know squat. These are Jacques type. What advice would you give the younger generation that are pondering going to the academia?
Yeah, so I'm obviously a fan. So I would tell them, if you enjoy research, then absolutely go for it. It can be a blast. It's awesome. An academic career is is so rewarding, well, for me. And you get to explore new ideas, you get to mentor students, and in many ways, I think their energy is what keeps me young, maybe
Ish.
younger than my sister.
I work with older people.
So often students ask me, I don't really like to do research, but I love teaching. Should I go? Should I get my PhD? And I'm like, I don't think so, because really PhD
Yeah.
is really about research. So I don't tell them not to do it, but I'm more cautious there because the academic route is almost always research involving.
And research does not just, translate into milk cartons and PVC thingies. It means writing papers and looking up stuff, although Chat GPT would all make that research much easier now. But writing. Oh, how do you write? Do you write your own stuff?
I absolutely write my own stuff. Plus, I've been writing for 18 years. So ChatGPT wasn't really invented then. ChatGPT has its place, but I don't know whether it can fully write a paper and be trustworthy. I have asked it before, can you give me some citations or, some ideas of who wrote about something, and they give me references that don't even exist. So I will never ask ChatGPT that again unless.
So how much time do you write? Do you spend writing being, boring?
Oh, yeah. Well, I would say on average 2 hours a day.
Okay, and how much researching? Like being fun and seeing subjects and doing MRIs and bending and clustering.
Well, see, the thing is that when we do that, it's like focused. We might do it for 6 weeks. We do fun stuff like that. And then we write for 3 months or something. And then we have to do the stats. And that's more like what people think academia is about. So there's short fun and long, maybe not so fun time. That's the rewarding part.
The not so fun? How long are you still planning on working doing research?
I don't really want to think about retirement because I love what I do. But my husband is kind of wanting to know how much longer I work because he would like to travel and go on cruises and stuff. So I said 4 more years is probably it.
Which puts you at 50?
35.
Oh,
yes, 50.
Yeah. Okay, so 4 more years, and then what?
Well, then travel. But to be honest, I love teaching and I love doing research. But in a way, I think I owe it to the students to give way to maybe younger folks who have different ideas. I don't know whether students necessarily love being taught by a, in parentheses, more than 50-year-old person. Because although I'm a dynamic person in my mind, the students might not agree.
Okay, so being a teacher, as in you standing in front of them and saying, this is how it's done, how much do this, so I have been teaching, I had taught too, how much do the students actually absorb from what you say versus what they get from the internet? Because the younger generation is born with a phone between their toes. So
between their toes? All right. Also, excellent question. We just started something new at, well, I don't want to say BYU, but we were told that we could start something that's called constructivism. So it's a teaching approach or a learning approach that uses just a different way, not just here, open your brain and I'm going to put a lot of information in there, but talk about tidbits. Like, for example, let's go back to the disc, right? This is how the disc gets nutrition. And this is what happens when you compress or distract, and this is this and this is that. And then the students will put their own knowledge together actively. And we're being told that research has shown that this is a much better learning, meaning they will retain it much better. And I dare to say probably much better than when they look it up on the internet.
So Jacques and I, we listened to something how AI has, and I didn't quite get it, but there's AI consciousness or AI something rather. But anyway, they basically say, if I might misquote it, so don't get me wrong, but somehow if you do it kind of what you said in different ways in all different corners, you don't get just this is the knowledge, but you can get hands-on, you know the physiology for it, you know the anatomy, you know the math, you know the English, and you know the German, and together it might come together. And if they're doing it through AI, somehow it's supposed to be the pinnacle of being fantastic. What do you think?
No, I don't think that is something I agree with. But then we have to consider that really the people that were born 10 years ago, they had a totally different upbringing and their brain works differently. So maybe it works for them. I don't think so, but I have been proven wrong before. So, for example, my kids, they listen to everything in 1.5 or 2 times the speed. Have you known anybody like that? To me, it sounds like, and I'm like, how can you even understand? And they do understand because I tested them. What did they say? So their brain is just a little different, evolved, I guess. And maybe AI does a better job than little me. But until I retire, I'm not going to have them talk to ChatGPT or another AI thing.
Before we come to the last, a very important question, do you have any shout-outs you want to shout out?
Ooh, wow, that's a surprise. Like
my son David and Madeline and my daughter Hannah and her husband and
I didn't know that was kosher. So yes, I would love to send a shout out to my loving husband who supported me to coming here. And of course, my kids and their spouses, David and Madeline and Hannah and Devin and my cute granddaughter, Winona. So, yeah, thank you for giving me a chance.
Oh, well, of course. Okay. Any other little tidbits for little knickknacks that you want to tell about how to prevent back pain, even if you already have it? Not prevent, but you'll get rid of it, possibly, besides sitting on your arms or not sitting on your arms and doing the 90-90?
I just want to encourage everybody to be active. Even maybe initially it might hurt more because your muscles say, wait a minute, I'm not used to this. Being active is so rewarding and it will most likely prolong your life. Just any activity is good. But can I real quick give you one more little tidbit in regards to learning?
Tootin', please do.
There is this saying that Benjamin Franklin gets credited for. It's tell me and I forget. Teach me and I remember. Involve me and I shall learn. I 100% believe that is the best way to learn. And that's what we're trying to do with this constructivism approach. I just don't know where AI has a place there. But as I said, that's just my humble opinion.
Okay. Do you have synesthesia?
Ooh, yes, I do. But
what is it again?
Well, so my twin sister has it very much stronger than I do. So what it is that 2 sensations are coupled that are usually not coupled. And there are different kinds of synesthesia, however it's pronounced.
Yeah.
In our case, we associate colors with numbers. Hers is very strong. You give her the number 4 and she says...
Well, 4 is not the strongest. But it would be a yellow.
Well, give me some that you have.
24.
So 24 is...
Orange.
24 is orange.
24 is orange, 19 is gray, 17 is light yellow, 99 is black, 66 is brown.
Wow. See, I don't have it that strong. If I think of a 2 or a 12, I think baby blue. to me that is, I can see it just floating in front of my mind. Or number 4 is also an orange, but I think yours was 24, right?
Yeah.
And we used to kind of argue.
Yeah.
Like I'd say 12 is baby blue, and she says, "What are you saying? It's not. It's whatever color it is."
Baby blue is 12, I can see. It's like 16 more, but yeah.
Hallelujah.
All right. So, but she also says, what is white? Hello. White?
0?
0?
Yeah.
Totally wrong. White is 1. 0 is 0 color, see-through.
She said 0 is too low to be white. It has to be 1.
Yeah.
I give 0 a chance.
Oh,
Yeah.
that's cute. Okay, well, then we are almost done. We have now, last chance? No? Okay, so we didn't speak because she just flew in here, so we don't, last chance, you're done. Okay, we have something called Fun Time Corner, where Jacques tells jokes and I laugh uncontrollably.
I might take her role there.
And I do quotes. So I don't have any quotes. I have just dumb jokes. So please feel free to laugh. I already said 2. So let's go on. Why do driving instructors make a good physical therapist? Because they can teach fine motor skills. Need to A physical therapist commented that a patient being passionate about the exercise felt like a stretch.
Yeah, so true.
Willst du mal eins erzählen?
Yeah.
Okay.
So ich habe hier einen.
Okay.
What did the pinched nerve say to the patient?
Wow.
Before physical therapy, I was just a pain in the neck.
Okay. I asked one of my physical therapist students how their classwork was coming along. They said it was a joint effort.
That works for my class.
Okay. Du bist dran.
So here's my special joke. I tell my PT that I try to jog twice a week. It's a running joke I have.
Although she does run. Not very funny. You know you're a good physical therapist when you turn heads every day. At work, at least.
We do anyway. We're good people because we turn heads every day.
Darn tootin'. If you're an anatomist, that is a polite way of saying that you're a people watcher.
You.
Oh, she's out of jokes. Why didn't the anatomy professor tell her students that they dissected the wrong body?
Ew, that's awful.
Because she didn't have the heart to tell them.
That's awful.
We have awful jokes. What common language is the most popular to teach anatomy?
Latin?
Body language. Very so Jackie. Some of them I chose, though. Okay, last one. I'm not sure why people always say that I have bad posture, but I have a hunch. I have a hunch. Sorry.
Do you have to do another one? This was bad to end with.
Okay. If you think about it, nothing begins with the letter N and ends with the letter G. She's thinking about it. Hey, you have been listening to the Doc and Jacques show on KCRW, Doc and Doc, KCRW 100.7 FM in Brookings, Oregon. We hope you have enjoyed this show as much as we have. Thank you, to my twin, Dr. Rike Mitchell. Thanks also for our sound engineers, Tom Bozak and Michael Gors and Linda Bozak at home. Thank you for listening, and you guys have a wonderful time. Also, the gang in Missouri. Bye.